So I was going to talk about CSF biomarkers, but I'm going to talk about fluid biomarkers because of where the field is going. This is what I'm going to cover. I'm going to talk about CSF biomarkers in Alzheimer's disease. What do we measure? Why is it important to measure biomarkers? And how do we practically do it? I'm going to give you one clinical case of how CSF can be applied, or CSF biomarkers can be useful in clinical practice. And then I'm going to talk about, for the last couple of minutes, where I see the fluid biomarker field going in the next 5 years. So first of all, the basics. What is a biomarker? And so it's defined as a characteristic that can be objectively measured and evaluated as an indicator of either a normal biological process, of a pathogenic process, or of a pharmacological response to therapeutic intervention. And that last point is really important, particularly in the current climate as we move towards disease-modifying therapies. And so why CSF, this intriguing fluid that surrounds the brain and spinal cord? Well, it's produced within the brain, it's in direct physical contact with the brain, it's in constant circulation around the brain, and it's rich in proteins that reflect brain metabolism. And so these proteins are most abundant within the CSF. If you compare to other biofluids like blood or urine, they're much more abundant, perhaps 50 times more if you compare to blood. There's a number of reasons why they're so abundant. They don't have to be broken down by organs like the liver or the kidney, and we don't think that proteases in the CSF have too much of a role in breaking down these proteins, at least not in the short term. So how do we use CSF in clinical practice? Well, the conventional use has been an exclusionary role to exclude inflammation, to exclude infection, to exclude malignancy in the context of cognitive impairment. But increasingly, we're using biomarkers to actually pinpoint evidence of the biological processes that are going wrong in Alzheimer's disease. So we use them to actually nail down the evidence of tau pathology in intraneuronal tangles, of amyloid plaque pathology, and neurofilament light, a marker of neurodegeneration. And in future, we're going to absolutely need these biomarkers to be able to track disease progression and actually be able to determine whether the treatments that we're giving patients to modify the disease course are working. We cannot just wait for cognitive impairment outcomes. So the next question is why? Why do we actually need biomarkers in clinical practice? Surely experienced dementia specialist doctors ought to be able to make a clinical diagnosis of Alzheimer's disease. But in the best specialist centres in the world, this is a PATH series from one such centre where they looked at patients with confirmed Alzheimer's disease at autopsy, and actually you can see that the sensitivity and specificity of the clinical diagnosis is pretty poor. So what we're saying is that 2 out of 3 times the specialist is getting it wrong. Or sorry, in 2 out of 3 cases they're getting it right, so 1 in 3 times they're getting it wrong. I think it's also slightly naive to think that our patients have single pathology. In reality, it's much more common that they have multiple disease pathologies, particularly at the end of life. And this is from a religious order study where they looked at patients with confirmed pathological diagnosis of Alzheimer's disease. And you can see that to actually have Alzheimer's disease alone at the end of your life was extremely rare, 3% of cases. Much more common to have mixed pathology. So Alzheimer's disease pathology, other degenerative diseases, and vascular disease, all in the same patient, much more common. So there's clearly questions about diagnostic accuracy, but it's also important to think about this from the patient's point of view. In the past, we've been happy to say to patients, we'll follow you up in a year, we'll follow you up in 2 years. But in reality, that's very anxiety-provoking for patients. And it doesn't give them or their family the opportunity to plan, and we deny them the opportunity to participate in clinical trials. And the last sobering thought, I saw this in a slide at a conference last week, where somebody presented the data from a phase 2 clinical trial of a tau immunotherapy. And they didn't include biomarkers for these patients in the AD group. And actually, when they retrospectively looked at their CSF profile, 1/3 of the patients had non-AD pathology in the AD group. So how are we going to make progress in clinical trials if we don't biologically phenotype our patients correctly? So this model will be familiar to many of you. It's a pictorial representation of the biological events that occur in Alzheimer's disease and how they can be measured with biomarkers. And you can see that the changes happen with amyloid deposition happening as long as 20 years before symptom onset. So cognitive changes happening late, but there's evidence of amyloid, tau, synaptic dysfunction happening well before that. So we need biomarkers to be able to pick these up. So what is in the clinician's toolkit for biomarkers in 2022? So I think it's helpful to think about this around the ATN framework, A being for amyloid, T for tau, and N for neurodegeneration. And we certainly have imaging biomarkers for all of these. Commonly available would be MRI, being able to see atrophy as your marker of degeneration. We do have biomarkers. We've got amyloid PET for amyloid and tau PET, but not really available clinically. An amyloid PET, yes, it's available in some specialist centres, but it's certainly not available everywhere. And you're exposing patients to radiation. It's time-consuming, it's expensive. And one might argue that CSF in a single procedure can give you access to all of these in one fell swoop. So let's look at amyloid first of all. What do we measure? Well, we measure A-beta 42 and the A-beta 42 to 40 ratio. Now, A-beta 42 is low in Alzheimer's disease. We think that's because it's absorbed within plaques, and so there's less CSF A-beta available to measure. And we now, since 2020, we use a fully automated platform which reduces human error. So that's a fully automated Lumipulse ELISA platform, which is pretty accurate. There's sensitivity, specificity, 95%, 89% validated against amyloid PET. Why do we use a ratio? Well, I think this has been a fairly significant advance in the field because A-beta 42 is absorbed into plaques, A-beta 40 is not. But since you're producing A-beta 40 and 42 in tandem, A-beta 40 corrects for the inter-individual variation. We're all producing amyloid at a different rate, and so this corrects for that factor. It also corrects for certain diseases. So if you've got normal pressure hydrocephalus and you've got lots of dilute CSF, having the 40 ratio will allow you to correct to some extent for that. Then let's look at tau. For those of you who are not familiar with the basic science, tau is a big protein which is very prone to post-translational modifications, and there are phosphorylation sites at multiple places in tau. And we used to think that the phosphorylation site wasn't particularly important, and so we chose to measure phospho-tau at the 181st amino acid. And that's slightly arbitrary, but that's what we're using in clinical practice. That's what the best evidence for is. But there are now other phosphorylation sites, which I'll talk about a little bit later on, which are a little better. And again, these are the manufacturers' sensitivities and specificities comparing AD against control. They're pretty good. We validated these in our own center. And finally, biomarkers of neurodegeneration. So you have total tau, which is a little bit, from a clinical chemistry point of view, a little bit of a clumsy marker as it measures lots of things. Neurofilament light is a structural protein, so it's one of the axonal proteins that is passively released in response to damage. And that certainly goes up non-specifically in lots of diseases, but it is a good biomarker of disease progression and neurodegeneration. We also have biomarkers of prion disease. And this is a fairly rare clinical scenario, but if you've got a patient who presents with rapid cognitive decline with onset less than a year, you might think about this. And certainly MRI with diffusion-weighted imaging has good sensitivity and specificity, but it's not as good as CSF. So if you look at total tau in your CSF, that tends to be spilled out into the CSF because we've got large pools of intracellular tau physiologically, and so if you've got a rapidly destructive process, that will be spilled out and measurable. And we have the RT-QuIC assay developed by Alison Green at Edinburgh, and this takes advantage of the seeding properties of prions, and it has a very high sensitivity and specificity, so that's specifically ordered from the National Prion Unit in Edinburgh. So lastly, how do we actually do it? How do we take CSF? This is a video in case anybody's interested. Carrying out lumbar punctures has typically been in the domain of neurologists, but this needn't be the case. We've shown that LPs can be carried out by specialist nurses in a daycare setting with low complication rates, low failure rates, and very high uptake for clinical research. It's not particularly expensive, and it's easy to make a business case to trust to do this. We have standard operating procedures, which are partially published in a practical neurology publication, and they're available to share. Contraindications, well, anticoagulation is the most common one, but in the elderly population, that is a significant exclusion, but the other contraindications are relatively rare. Another couple of the sort of small print ones, having a big tumour with raised intracranial pressure or having a Chiari malformation are clearly contraindications. Side effects, about 10% of patients will get a post-lumbar puncture headache. In reality, in the dementia population, this will be about half of that, about 5%, due to the increased CSF volume. The do's and don'ts of lumbar punctures. Well, over the last 10 years, we've done a lot of work establishing which factors are important for the patient, for patient safety, and also for the reproducibility and validity of the results. And from a clinical perspective, it is important to use an atraumatic needle because that reduces your risk of headache by about half. And then in terms of pre-handling, the key thing here is you must use polypropylene tubes. Amyloid is sticky, it sticks to everything. If you put it in a normal tube, you will falsely diagnose your patient with Alzheimer's disease potentially. And the rest of the factors to consider really are for your lab to consider rather than you as clinicians. So let's quickly look at a case. This is a case from my cognitive clinic. A 64-year-old man presenting with cognitive decline over 18 months. His first symptom was difficulty using a screwdriver at work. He then developed problems handling change, spelling, and his wife was concerned about his lane discipline when driving. His memory is now affected. His ability to comprehend language has deteriorated, and his speech is hesitant with word-finding pauses. Has a history of anxiety, but takes no medication. No family history. So his imaging showed questionable parietal atrophy. Radiologist wasn't sure. Mild hippocampal atrophy. Again, not sure if it was abnormal for age. So here we've got a man with a progressive praxis-led syndrome over 18 months, now with memory, and he's young. So according to good practice, American Academy of Neurology, Alzheimer's Association, NICE guidelines, it's reasonable to get biomarkers in this situation. So we did a lumbar puncture. No evidence of inflammation. You can see that the A-beta 42 to 40 ratio is low, convincingly low at 0.027 with a cut point of 0.065. You can see that the phosphorylated tau level is 400, so that's the upper limits of the assay with a range of up to 58. And neurofilament light, again, 4 times above what you would expect, even adjusting for age. So my interpretation of this would be that there's no evidence of inflammation or infection. There is evidence of amyloidosis, as evidenced by the A-beta 42 to 40 ratio. There is evidence of a tauopathy, as evidenced by the phosphorylated tau, and there is evidence of neurodegeneration. So from ATN perspective, he's positive for all 3. And how did this help us? Well, I was able to give him a diagnosis of Alzheimer's disease promptly. He was started in donepezil, referred to the rare dementia support group, and he was provided with information and referred on for clinical trials. Okay, in the last couple of minutes, what is the clinician's biomarker toolkit of the future likely to look like? So we've spoken about imaging and CSF. The main difference, I think, is going to be with blood. So we're at the stage of having biomarkers of the 3 pathologies in blood. So at the moment, there already is a mass spectrometry-based assay looking at the 42 to 40 ratio, which will allow you to diagnose your patient using mass spectrometry. This isn't available everywhere, and it hasn't been translated through to clinical practice, but I don't see any reason why it won't. The phosphorylated tau assay, again, there are both mass spectrometry and there are immunoassays for these other phosphorylation sites and for 181. And a biomarker that's not of the future, that's of now, is neurofilament light and plasma. So CSF, plasma neurofilament light, highly correlated, and as of earlier this year, the Queen's Square Neuroimmunology Lab can test plasma NFL for you. So that's clinically available. It costs the NHS £85. Oh, and I couldn't help showing a picture of my friend and colleague Nico Bartolome, who did some of the seminal work on developing the Tau 217 assay. So in future, In our biomarker toolkit, I envisage that we'll have clinical biomarkers for synaptic dysfunction, for neuroinflammation. But I think there will also be considerable developments in how we use and interpret existing biomarkers. I'm over time, so I probably won't dwell on this too much, but one particular thing that I want to raise is, I think using rate, introducing time into the equation, I think will be really important, because we're interested in a disease of protein disequilibrium. We need to understand whether these proteins are produced in excess or whether clearance is failing. And so we do have a technique known as the stable isotope labeling kinetic techniques, where we can give patients isotope, measure the rate of production, measure the rate of clearance by taking multiple CSF time points, which we're in the process of doing for the various dementias. So in summary, lumbar puncture is well tolerated, SOPs are available, CSF biomarkers available for amyloidosis, tau and neurodegeneration, RT-QuIC for prion disease, blood biomarkers are on the way with neurofilament light for neurodegeneration already here. These are my disclosures and funders. Thanks for your attention.
The outward-facing topic of my talk is essentially, do real-world populations differ from clinical trials? And everyone here knows that, of course, they do. So perhaps a more appropriate title would be, how do they differ from clinical trials? And so really the talk today, I want to talk about how real-world populations differ from those of clinical trials, and does it matter? A lot of the work today comes from a paper that I wrote with John Schott earlier in the year, which was really a meditation about this issue and really whether comorbidities had been an obstacle to developing effective treatments. Obviously, the conversation has changed a bit in the last few weeks, but I still think, the facts remain that we look after a population of people that have multiple comorbidities, and actually, in many ways, the dividing line between a comorbidity and a feature is quite blurred. So, for example, if we're talking about vascular disease, is that a comorbidity of Alzheimer's disease, or is it a feature of the pathological process that's going on in those patients? I want to talk, first of all, about what the inclusion criteria were for the lecanemab, the Clarity trial. We've mentioned these already briefly today, so we know that people had to have meet diagnostic criteria for either MCI due to Alzheimer's disease or probable Alzheimer's disease dementia. They had to have a CDR score, a CDR score of 0.5 to 1, and a memory box score of 0.5 or greater. They also needed to describe evidence of subjective memory decline with gradual onset and slow progression over at least a year, and that needed to be provided by the participant and an informant. So, in those terms, I think we would agree that these sound like people that have Alzheimer's disease. I don't think there's anything there that we would particularly dispute. But it's the exclusion criteria that I think are slightly more problematic, perhaps. I make no apologies for the next two slides being incredibly wordy. That's there to emphasize my point. So who wasn't allowed to be in this study? Well, people who had any condition, any neurological condition that could be contributing to their cognitive impairment above and beyond that caused by their Alzheimer's disease. Anyone who had a TIA or stroke or seizure within the 12 months before screening. Anyone with any psychiatric diagnosis or symptoms that could interfere with the study procedures. And in particular, they were looking at depression. So the GDS scales out of 15, 5 or more suggests probable depression. And anyone with 8 or more couldn't be involved in this study. Fairly understandably, anyone who couldn't have an MRI scan couldn't be involved in Clarity, but also those whose MRI suggested something else, another cause of dementia other than AD, were excluded. And that's not it. So they also, if they'd had an MRI that found other things, so if they had an MRI that showed multiple microhemorrhages, if they'd found an MRI that showed encephalomalacia, aneurysms, vascular malformations, multiple lacunar infarcts, strokes in major vascular territories, small vessel disease, space-occupying lesions or brain tumours. Of course, lecanemab is an immunological therapy, so anyone that had any immunological disease that was requiring treatment couldn't be involved in the study. People who had bleeding disorders that weren't adequately controlled couldn't be involved, and those who were on anticoagulants obviously couldn't have the CSF elements of the study. And most broadly of all, anyone who had any other medical condition, be that cardiac, respiratory, GI, renal, which was not stably or adequately controlled, or which could affect their safety or interfere with the assessments. So I think when we think of all these criteria in the round, it begins to be quite clear that the people who are taking part in Clarity aren't really the same people that we see in our memory clinics. And there's obviously lots of reasons why that's okay. It's a safer approach. What they're looking for is to find people that have the purest form of Alzheimer's disease. But I think we have to bear this in mind. And this is something that we haven't really had to do for quite a long time in memory clinic, is think about the difference between clinical trial populations and the real world populations. Also importantly, people that took part in Clarity had to be either older than 50 or less than 90. They had to have a BMI of greater than 17 and less than 35. And I think quite importantly, they had to have an identified study partner who could be with them for the duration of the study and spends at least 8 hours a week with that person. And again, I think sometimes we often see people who don't have someone and they see that reliably. And that's before we even talk about some of the things we mentioned this morning, such as ethnic disparities and economic ones, which might also affect who gets to take part in clinical research. So why does that matter? So I want to talk briefly about a few things and then in a bit more length about epilepsy, because that's my pet interest. So why does it matter if we exclude people that have other neurodegenerative diseases? Well, as we've already pointed out today, because it's very common to have multiple things at once, and it's also common that we don't quite get things right. So these pie charts come from a paper in Brain in 2018, and what they show on the top line shows pie charts representing idiopathic Alzheimer's disease and hereditary Alzheimer's disease. And what you can see there is, in these post-mortem studies, only about a third of patients had pure Alzheimer's disease. The remainder have a mixture of alpha-synuclein, TDP-43, or those things in combination. We also know that other diseases such as PSP, CBD, quite commonly have Alzheimer's pathology, amyloid and tau. It also matters because we know that people that have multiple pathologies get worse more quickly. So this second figure here shows people that have Lewy body dementia, and what we see is those that have Lewy body and Alzheimer's pathology were getting worse significantly more quickly. And why does it matter if we exclude people that have vascular disease from our cohorts? Well, I think we know that the kind of historic paradigm of memory clinics, certainly when I was training, was that people come in, they have a CT scan. If the CT scan suggests lots of vascular disease, we say they probably have vascular cognitive impairment. If they don't, we say they probably have Alzheimer's disease. And in an age of disease-modifying treatment, that divide doesn't really hold water. And I think we need to be better at knowing who has what. But we also know now, better than we used to, that it's not uncommon. In fact, it's probably the norm for people that have Alzheimer's disease to also have vascular changes. And note many of these things were excluded from Clarity. So people who have small vessel disease, microbleeds, strokes, all of those things can be features of the pathology of Alzheimer's disease. We know that the deposition of amyloid in blood vessels leads to amyloid angiopathy, for example. And so we need to think about these people and bear in mind that they weren't involved in the clinical trial for lecanemab. What about depression and anxiety? Well, virtually everyone here, I'm sure, is familiar with this figure from the paper a couple of years ago now, which is really showing some of the modifiable risk factors for the development of dementia. And amongst those was depression. Depression is alongside smoking, physical inactivity, and diabetes as a later life risk factor. And it seems strange that we would exclude a risk factor from a study that's looking at a cure. So it's like saying we're going to do a study for lung cancer, but we're not going to have any smokers taking part. It's a strange thing to try and take those people away from this research. And also because that relationship is bidirectional. So we know that people that have Alzheimer's disease have an increased risk of having depression as well. So again, the clinical study cohort becomes less and less like the real world one. And now to talk about epilepsy, which I was saying is kind of my particular area of interest. So it's been known for a long time that people that have Alzheimer's disease in particular, but all forms of dementia really, have an increased risk of developing epileptic seizures. For a long time, the established wisdom on that was that epilepsy was occurring as a late-stage manifestation, only developing after significant atrophy and degeneration had occurred. But actually, we know now that's not really true. So we know, this first figure here is from a paper which was new out when I started my PhD and is now 6 years old. And it shows 77 people that had Alzheimer's disease. Each line represents an individual. And on the y-axis, you have the number of years from their dementia diagnosis to their seizure onset. As we might expect, about a third of those patients developed epileptic seizures more than 5 years after their dementia diagnosis. But a similar proportion, about a third again, were developing seizures before dementia was diagnosed, and many were developing it within the first year or so. So I don't think we can really say that it's purely a late manifestation of Alzheimer's disease. It also matters because people that have seizures get worse more quickly. So the second figure here shows two lines. In green, you have people that have Alzheimer's disease and entirely normal EEGs. The orange line represents people that had Alzheimer's disease and epileptiform features on their EEG. And what you see is those that had epileptic features get worse significantly more quickly. Here, the measures they used were an MMSE and a composite executive function measure. So both groups were starting off from a baseline of about 25 on the mini-mental. It took the normal EEG group about 3 years to get to a score of 22. The other group got there in about half the time. So within 18 months, they were dropped down to a 22. So they're getting worse more quickly. And that's kind of was found again in the work that I did for my PhD. So we had a cohort of people that we got from the memory clinic, and we divided them essentially into three different groups. Those in whom we had no suspicion of epilepsy, those in whom we thought there was some suspicion, and those in whom we thought there was definite evidence. And they were people who had had at least 2 seizures that had been witnessed. And again, what we found here was that they were getting worse more quickly, and that was measurable over just a 12-month follow-up. And that was measured across using the Addenbrooke's as the cognitive measure, and particularly they were getting worse over measures of fluency, language, and visuospatial skills. So what's happening? Well, this is a really elegant figure from a paper from Michel Rumely last year, which essentially is describing what I'm saying here, which is that we know that in people with Alzheimer's disease, amyloid and tau build up, and we know that that leads to hyperpolarization of the neurons that makes them more prone to epileptic seizures. There's also evidence that seizures themselves can increase the spread of both amyloid and tau. And so people get into this cycle where they're having seizures makes things worse, the worsening makes them have worse seizures. So again, going back to the exclusion criteria from the start of this paper, people who had had a seizure in the last 12 months weren't able to take part. And I think, given that epilepsy, again, can be a feature of Alzheimer's disease, it seems surprising that we would exclude those people. So, in conclusion, obviously, the AD that we see in clinics is not the same as those we see in clinical trials. It's important to recognize that comorbidities are common in the people who we're looking after, but more than that, they're often directly related to the AD pathology, which we know is there. What does that mean when we're talking to patients in the clinic? Does it mean that the risk of side effects are higher? Does it mean that the probability of benefits are lower, potentially? What we need to do, and what hopefully will happen over the coming years, is that as more drugs become available, we need to build real-world evidence that can help support these discussions. But in the meantime, we'll have to carefully discuss what this means if we have a patient in our clinic who would be suitable for lecanemab, but they've had a major vessel stroke. What do we do? Do we say that they can't have it on that grounds? We also, it's an important reminder that we shouldn't miss chances to discuss comorbidities in the memory clinic. All these things we've mentioned, vascular disease, depression, anxiety, epilepsy, have treatments available for them, and we shouldn't miss the chance in the clinic when we see a patient who might describe these things to prescribe them treatments that might be effective for them. Do I think that a bit of a kind of a monotheistic approach to Alzheimer's disease limits the development of effective treatments? Perhaps, but perhaps not. This figure from the drug development pipeline from last year shows that actually we're doing quite a good job of trying to think of different ways of tackling Alzheimer's disease, be that through amyloid, tau, vascular changes, inflammation, and other causes. And I suspect as we move forward, we'll realize I'm normally a glass half full person, so I don't want to be a downer about all this. But I do think that, that it's likely that lecanemab won't be the answer that we're all looking for everybody, and I think we'll have to continue to focus on different pathways to treat people with Alzheimer's disease in much the same way as we do with oncology, for example, where there isn't often a single drug that will do it. We're trying several things in concert. Just finally to say thank you to everyone who I've been involved with. So I've been at Exeter before. I had a bit of a kind of PTSD. David Llewellyn was one of my examiners, and he's here today, which was slightly stressful. And since then, UCL, and as I was saying, thanks to the funders which have included AI UK and others over the last 5 or 6 years. Thank you very much.